Hello, my friends. I thought tonight we would recap some news from the week that was related to healthcare stuff. We're going to be starting out with talking about kidney failure and kidney transplants. Now, there was a huge change recently where they changed some of the ways that they determine if you can get a kidney transplant and when, and they made it a lot less racist. So we're starting off strong. That's wonderful. We'll kind of go through what those parameters are, what they changed, and why. We will be talking about scrubs. What color scrubs should you be wearing? And apparently, there's one color that you definitely should not be wearing, which is one of my favorite color scrubs to wear. So it's very unfortunate. Let's see if you can guess what it is. That will be segment 2. We'll be talking a little bit about the NHS strikes over in the United Kingdom. They have some strikes coming up because, their situation is just rough, similar to here. We'll be talking a little bit about intermittent fasting. Get ready. Do you like intermittent fasting? Let us know. We will also be discussing some antidepressant, anti-anxiety news. There were some articles that came out that just kind of made me annoyed. So I figured we'd throw them in here. And we're going to wrap up with some good news. If you're watching live, welcome. Hello. Tell us where you are listening in from, how your day's going, all the things. And if you're watching on the replay, hello, welcome. We appreciate you. Like the video on your way and do all the things that the YouTube gods love. And let's see if we can get through these topics. Okay, let's see. We used to do this. I've been playing around with doing these types of weekly recaps. I was doing that with the whole panel. And then I realized there's probably too many people that we like to chat and discuss, like Mr. Midwife and Jay Michael. I was like, there's too many of us and we get off on a weird tangent. So there's too much. So we're going to try doing it on Tuesdays here. If we like it, let me know. I like it. So, you probably should like it too. If you're not though, you can let me know. And then this Friday, just as announcements before we get started, we will be talking about the whole hostage situation that happened in a hospital recently, where a lady shot her husband, and yikes. We'll be talking about that as a group. We'll have lots of insights. It's going to be a conversation surrounding that, but also end of life care and how we really suck at it in this country. So that's what we have going on for the week. And for tonight, let us dive right into our first case. So our first case, as if this is a case. Well, it's an article. We'll call it a case. Oh, too many years. So starting off, let me know if you have any familiarity with kidney transplants. Okay. I am fairly familiar with kidney transplants in that I worked on a GI liver kidney failure floor. So a lot of my patients went off to have a kidney transplant, and sometimes we took care of them right afterwards. And I had a lot of patients in primary care who were on the list, or I've had a lot of patients who I had to clear to in order to go and donate kidneys. So I feel like I'm somewhat familiar with it. Today, or yesterday, within the news in a few recent days, it changing the requirements or the rules surrounding getting a kidney transplant. So with most organs, right, when you need an organ, you have to meet parameters in order to get a kidney transplant or any transplant. And it's very, very this awkward line where you need someone to be sick enough so that they require a transplant, but they can't be too sick, because if they're too sick, then they are going to they're going to either pass away before they get it, or they will be so sick that they won't be able to recover. And that has been it's a balance, right? It is a difficult type of thing. Interestingly, different places get to decide, different transplant centers, like different kidney transplant centers, they kind of get to decide what their parameters are going to be. And a lot of places, it's kind of cut or dry, right? In order to get a liver, you have very set values of you need to have what's called a MELD score sometimes, of, this is where your liver failure is. The values are, it is what it is. That is not the case with kidneys. Kidneys, and it's not the case with kidneys because we assess kidney function based on something called your glomerular filtration rate. I'm going to mess that name up. Okay. I cannot say that word to save my life. But the thing is that we don't measure it exactly because it takes a long time and it's very labor intensive to get that exact glomerular filtration rate down. And what that is essentially a glomerulus is a little thing that lives inside your kidney, and it's the filter. And the worse off your kidney is, the less it's going to be able to filter. the lower your number, right? If you have a wonderful, healthy kidney, your glomerular filtration rate, or we're just going to call it GFR. Yes, AdChem, we'll just call it GFR. It's so much easier. GFR is what we're looking at here, friends. Glomerular filtration rate. Say it like 7 times fast. I bet you can't. Your tongue goes like, blah, blah. And then your patients look at you like, are you okay? But if you have young, healthy, thriving kidneys, that number's super duper high. It can like pump through a whole bunch. It's like, watch me. I can filter all day. Let's keep going. And if your kidney is sad, it's going to be lower, right? We start saying that kidney failure starts, I begin to worry about you, or we start the conversation of like, I have concerns at like 60, super young, healthy kidney. We're at 100, right? And you are in grave danger 20 or 30 and below, right? So that's just kind of the spectrum of what we're looking at. Historically, if you've ever gotten lab values, you probably had this on your labs, and it probably said eGFR, because remember, the glomerular filtration rate is how we measure kidney function, but we don't actually measure it that way because it's very complicated and it takes a long time. So we use algorithms and we estimate it. Now, unlike with other labs or other like ways that we screen things, an estimated glomerular filtration rate, which will show up as eGFR on a metabolic panel, if you ever get one, I'm sure you've gotten one of those if you've gotten blood work, they estimate it based on a few different criteria. And that criteria changes based on the lab and how they determine like what they want to look at. And so everyone kind of gets to pick their own, which is weird. And so every single different like place that's doing a transplant can also pick the parameters of what they would like to use to estimate glomerular filtration to decide if someone's eligible for a kidney transplant. And it just seems odd that, it's standardized, but not really, because you can pick within that. Now, you're like, why does all of this matter? Up until this year, you had 2 numbers. If you looked on your labs, it would say eGFR and then African American eGFR, or it would be flipped around the other way of like non-African American eGFR. Because when they were developing a lot of these estimations, some people found that one of the things that goes into this evaluation is they look at something called a creatinine, which is when your muscles break down normally over time. It releases a protein called creatinine, and your kidneys, it's their job to shuttle this out of your body. If you have more muscle mass, you have more creatinine. And people, when they were researching this forever ago, said, oh, it seems that Black people have like more muscles. So even if they like have more creatinine in their blood, I'm sure that's normal across the board for all of them, because everyone is the exact same type of human. And so they need to be sicker, because if you have a naturally higher creatinine, then we expect you to have the higher your creatinine, the more sick you usually would be if you had a super high creatinine. So they said, well, since you normally have more of this in your blood, we're going to add a few points to your score, your eGFR score. So even if you're super duper sick, we're going to give you a few points anyway, because we've decided that as a whole, yeah, you have more of this. So it's just fine. Outcomes, they realized later, were poorer. They were like, oh, wow, like this doesn't make very much sense, because like if you look at outcomes broken down into like, oh, if you're Black, you tend to die of kidney failure more than if you're white. There's a lot of different things that go into that. But part of it is you get less transplants because we mess with this number, right? And it's not cool. We don't like that. They finally have acknowledged that, wow, people are not a monolith, and perhaps we should stop treating them as such. So I pulled up this article and then I just spouted the whole thing at you anyway. But that is what they have finally decided to switch here today. And we are very, very happy about it. I have hated for years when you would read over lab work with patients and they're like, why is my number different? They're like, so does that mean my number is different? And you had to be like, yeah, our healthcare system is pretty inherently racist. And I have no other excuse. So hopefully they just take it off now and we can just use estimated glomerular filtration rate. The thing that they changed was you are not allowed to use any race-based anything. Remove that from the equation. Everyone just gets the same test. 2023, friends. 2023, and here we are. We're finally using the same test for people. It's great. So this kind of goes over the reasons why it's an unprecedented move to correct racial inequality in access to kidney transplant and board certified waiting time approval of Black transplant candidates. What they were finding again was that if you were Black, you were waiting longer for a kidney, and then more people died because then all of a sudden they were like, oh, wow, you went from like, to, and why does this keep happening? Well, we wonder. We just keep looking at it. And that's what we saw. Black people are almost 4 times as likely to be diagnosed with renal failure as kidney failure as white people, but are often diagnosed late, and it takes longer to get on transplant lists. Because again, let's say the transplant cutoff on an estimated glomerular filtration rate was 20 and your GFR came back at 20, they would, if you were Black, they would give you 2 more or 3 more points. And they were like, oh, we'll just give you a couple more points, and which would bump you off the transplant list until you were sicker, right? Yikes. Yikes. Off of data where they decided that every single person, all of you, that's, I'm sure all, like everyone, yikes. Let's just stop pretending that if we have a subset of data, that small subset of data speaks for an entire population, okay, who just happens to have a little bit more melanin. Maybe we should stop doing that. But oh, yes. Yeah. Jail nurse. Exactly. Jesus. 2023. Here we are. Well, I mean, it's good. It's just frustrating that it's taken this long. If you are curious, this is the actual place where who got to decide all of these fun facts. This is going into effect. It went into effect January 5th, 2023. Kidney programs are required to assess their waiting lists and correct waiting times for any Black kidney candidates disadvantaged by having their kidney function overestimated due to a race-inclusive calculation. We have communities of color are disproportionately affected by end-stage kidney disease. So we can do all within our power to ensure they receive the utmost life-saving care. Great. We're here for it. We like that. For a number of years, some EGFR calculations have included a modifier for patients who identified as Black. This practice led to a systemic underestimation of kidney disease severity for many Black patients, again, because we're very numbers specific when it comes to treatment of kidney disease as well. So this would apply to all sorts of things where it was like the nephrologist, the kidney doctor, won't see you until your GFR is 40. I would have to wait a few more points for someone, if they were Black, to send them to the nephrologist until their GFR hit 40. Whereas if they had been white or literally anyone else, they would have been able to go. And so you're delaying that kind of care. And this kind of has a trickle down effect. There were, let's see, I think I had over here. It goes over, I'll leave this link down below, what the EGFR is. Some people use EGFR in their assessment of patients. This is one of the things they use when they're deciding, do you get a kidney? That is the primary lab value that they are going to use. They found a ton of errors. I'm trying to find where they gave us a bunch of errors and like, here's how many people we think we oopsed before we changed this. I want to say it was like 80 something percent where they were like, oh, this is probably not actually representative of the sample. So there we go. That's where we are. I'm very glad that we were able to actually get around and do something about this. This is a great step in the right direction. And hooray. Hooray for very small wins. Let me know if you have any questions about that. I feel like I'm teaching a class. Do you have any questions about this? Do let me know. The jail nurse explains the astronomical numbers of African Americans patients on hemodialysis versus getting transplants. Yeah, the list is long, my friends, that people are on it. And then, like I said, it's very unfortunate that you get delayed intervention. You get sicker, right? You get to that sicker point before you can actually get a transplant and can actually do anything about it. So step in the right direction. We're proud of you. If you want to read about more of it, it's interesting to read about like all the kidney function and all of that. I used to love talking to my patients about kidney fail. Like, not that I love talking to them about kidney failures, but kidneys like make sense. They're just like filters. They're like hearts. It's not like some of those other systems in your body where you're like, I don't know what that is. What is that? Why is it here? This is confusing. Jail nurse says, and why is it so hard to get and why it's so hard to get inmates, the majority of which are African American, disproportionately in to go see nephrology. Yeah, we're also very short on nephrologists. And so they'll triage people to who has the worst filtration rate, right? Well, you have to be sicker in order to have the filtration rate here. It is time after that, which was not bad news, but just frustrating news. We are in our first, I was going to call it a mouthwash session. It's not a mouthwash. It's a more of an entertaining story. I'm trying to find some of those that we can sprinkle in and leave here, as fun little nuggets. So earlier I asked you, what scrub color do you like the most? Okay. I particularly enjoy if I'm having to just wear a palate cleanser. Thank you. What is this called? I know it's not like a soap scrub. Yes, a palate cleanser. What color scrubs do you enjoy? Someone did a study recently, Mr. Midwife. I would fit in at your practice because black, yes, black scrubs are where my soul lives, with like a fun t-shirt under it, or a t-shirt and then scrub pants, but black. Black, it hides a lot of things. It's a flattering color, right? Blue and black, perfect. We're in for good things. They did a study on this. Now, it wasn't like the most scientific thing of all, and it was on surgeons, but still, we're going to go with it anyway. Maybe the data would be different from nurses. I really kind of hope that it would. And it's also from JAMA, and we hate JAMA, but this article was interesting, so we're here. Seal and blue and navy. Seal blue. I don't even know what seal blue is, but I'm proud of you for knowing that word and using it. But I like the sound of it. No, let's call it mouthwash and confuse the F out of people in conversation. I just need some mouthwash real quick and spout out some random funny story. And they'll be like, what on earth? Clayton likes maroon. The jail nurse likes black. I love all of you people who enjoy wearing black scrubs with me. Yes. Spoiler alert. We're about to have a really bad time. So JAMA, Journal of the American Medical Association, the actual devil, came out with this article on January 11th. And they said, association between patient perception of surgeons and their scrub color attire. Now, please just hold on to your seats for a moment while we look at this truly alarming graph. Okay. Can we make it bigger? We can. So they had people, they dressed them up in black scrubs, light blue. Is this seal blue? Maybe it is. Green, and then navy blue scrubs. And they said, how do you feel about these people? And they rated it on a couple of different scales. Okay. And it's not going to go well, guys. It's not going to go well. Female clinician vibes versus male. And it was kind of the same, friends. People who wore black scrubs were seen as the least knowledgeable, the least skilled, the least most trustworthy, and the least caring for both men and women, but particularly for women. People hated when people wore black scrubs. Like, you are the worst. Jasmine wears black for sure, and pink because it's my favorite color. Exactly. Okay, seal blue is light blue. So yeah, friends, our favorite scrub color makes us seem dumb, unable to do anything, not very trustworthy, and not very caring, which doesn't really go with my resting bitch face that I usually have. And maybe that's why people were sometimes scared of me, because they probably sat over in pediatrics like, they were like, ooh, yike. Yeah, this is extremely disheartening as a future nurse. I mean, to be fair, this could be a strategy, right? To just scare everyone off, and then no one will want to deal with you. They'll be like, not you, not if you're wearing the black scrubs, and they'll just leave you alone. And maybe people won't expect anything from you. And so if you have like an ounce of a brain cell, they'll be like, wow, look at you. This was actually absolutely great. We'll see. We haven't hung out, Mr. Midwife. I do have some pretty raging RBF. When we're like ever, one day I hope we'll hang out and you'll see it happening. J. Michael could probably speak to that. Sometimes like, well, are you okay? I'm like, it's just my face. Okay, I'm sorry. Grassroots says, dang, I'm dumb and I have RBF. Let the patient complaints roll in. That's what I'm going to blame everything on, when they were like, that nighttime nurse. Something was wrong with her. It was my scrub colors. Okay. It was my scrub colors. I can't see my scrubs if they're sedated. When you care for patients, but don't care. Want to care for patients, but don't care for people. Oh no, I butchered it. When you want to care for people, but don't care for people. That's our vibe there. That's our vibe there. And I'm here for it. Um, you can still be nice and have RBF. This is like how I interact with the world. That's kind of the look. And I cross my arms because I have really long arms. So I tend to just be like this in public. And I've been told it's not very approachable. And then people are sometimes shocked, like afterwards, like if I was like when I was working as like a nurse or even especially as a nurse, because the people in my office as an NP, they got to know me pretty well. But as a nurse, people were like, wow, like when they would talk to me, they're like, you are not as scary as I thought you would be. And I was like, oh, thank you. That's a weird compliment. But thank you. Oh, thank you. So I agree. So I guess we're not allowed to wear black. Navy blue scored the best, in case you were curious. Navy blue was the most, it scored like universally highest, and like, you're the smartest, you are the most skilled, you are the most trustworthy, go Navy blue. And then light blue, and then green, but overwhelmingly black. Overwhelmingly black. I mean, tips as a bartender, because I never stopped moving, right? I have RBF when I'm just like not doing anything. But when I was a bartender, I was like, la, 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 la. And like, just chit chatting, doing my thing. I'm sure sometimes I had RBF, but most of the time I was probably like, if I'm chatting, there we go. I've been called to be so many times, and I'm like, this is just my face. Exactly. My children even know it. Sometimes my youngest will be like, why are you mad, mommy? And my 5-year-old's like, that's just her face. She's like, that's just mommy's face. Mommy's face looks like that. It's like, oh, but thank you. This is a good question. But the big question is, where does orange fit on the graph? Orange is a bold color, my friend. Orange is bold. I'm with whoever's Jazzy, was it you said you like pink? I like pink, but like that bright, like kind of fuchsia-y, like bold pink. I think it was green is for the OR. Yuck. This was for surgeons again. So we kind of have to give them some bias. I think the best scrubs are like the Disney scrub tops and then like pink pants, like very different. Cause that's what I wear to work. I was either in all black or like I came in like a Disney rainbow. People were probably like, whoa, it's very different. Very, very different. So there we are. KM, we're talking about scrubs because this is our palate cleanser, right? Or our mouthwash. This is our conversational mouthwash so that we don't get overwhelmed with yuck. But here we are. We can dive right back into the yuck. Okay. This yuck is happening over in the United, is it the United Kingdom, or is it Great Britain? In my head, they're the same thing. They very much might not be the same thing, and I probably should look that up. So a few weeks ago, Nurse Adrian, you guys know her, and I got to interview Siobhan. She is a nurse from Scotland, and she gave us all the inside deets on the NHS strike that was happening a few weeks ago. They went on strike for 2 days in December. If you want to watch that video after this one, go do that. It was incredibly insightful of just like this situation of healthcare in the NHS, which is over in the United Kingdom, or is it Great Britain? Guys, help me out. Which one is it? It's over there. And I'm like, I feel like, so side note, in this conversation with her, I kept like saying weird things like that. And I work for a German company, and it's like all the time. They're like, wow, Liz, you are like the most American person. I'm just like, I don't know a lot about other countries, and I probably should. And I'm sorry. But anyway, this is what you can go watch that to kind of get a backdrop of the situation. Essentially, they're paid like crap, right? Nurses in the NHS, which is the National Health Service, are paid like absolute crap and have crazy unsafe ratios. Darren says it's the UK. We're going to go with the UK. We're going to be here for the acronyms today. Across the pond. That sounds even better. Across the pond. I will not torture you and read this entire thing in a British accent, but I am told I have an excellent British accent by my children who love Peppa Pig. So that was, is there higher praise than a Peppa Pig fan telling you that you have a very accurate accent? I think not. Okay. I think not. They're going to have another strike here. It's going to be a dual strike. Okay. We're going to have nurses and paramedics going on strike. So this article from CNN says most winter headlines warn British National Health Service is at a breaking point. Alarm sounds over and over and over again. The current crisis has set warning bells ringing louder and louder than ever. I thought they had a very interesting graph where they showed that their wait times in the emergency room have just like gone bonkers since COVID. And I don't know if it's because a bunch of people quit and we're just like, I am over this, right? And are bailing or what the deal is. But ever since like COVID happened, right, their wait times in the ER for like, if you're measuring, like, this isn't a total measure of healthcare, but people who had to wait more than 12 hours in the ER, it's gone like up quite a bit, 50% higher than it was in 2011. So I think people are over it, right? And they're quitting over there. And not ideal, right? We have similar issues here. There's having similar issues over here. If only everyone could get their act together and be like, wow, let's just maybe put a little bit more money towards healthcare and treat people decently. It was interesting having a conversation with Siobhan a few weeks ago because she was able to shed light on like a lot of the reasons why they're not getting a lot of funding. There seems to be a squabble about like some people are trying to they're pulling funding away from their health service because they want to come in with like a system like ours where you like pay for everything, not from like taxes, but like to where it's privatized. So they're trying to, some people think they're trying to make it like so bad that having privatized healthcare seems like a great option. Which I was like, you have to be tricked into that. That is the only way. So that's kind of what I understood of the landscape behind it. So it's a mess. They don't have funding. We don't have funding. It is a hot mess, but they're having a joint strike, which we will probably talk about here. They are having the paramedics and the nurses are teaming up to go on a strike because, like this is saying, they are after COVID, things have kind of just gone like, bleh. You'll hear lots and lots of stories of just, everyone is leaving, right? It seems that bits of the system aren't fitting together anymore. This person had said it's not just about how much staff there are, it's about money, how much money there is and how it's being used. And then it kind of goes further into, what we were kind of talking about of who's pulling what strings and where that is all going. This is I should probably share it with you. That would be helpful. So they are going to have a strike on Monday, February 6th. So we can maybe cover that a little bit more when the date comes close, but always good if you see people like sharing or posting about it on social media to go and share that information because it shows people, it gives a little bit of solidarity to our friends over on the other side of the pond who are probably feeling a little bit attacked. And because going on strike, no one ever wants that. In the video, we also talked about how strikes are different there. So they strike for like 12 hours at a time. And like literally, you just don't go to work. They don't fill the spots and they don't strike on all the units. So like the ICUs don't strike, pediatrics doesn't strike. It's just a very different way of doing things, but it was very fascinating. So you can go check that video out after this one. But they are planning a coordinated walkout on February 6th. They're warning it could be the biggest day of industrial action the NHS has ever seen. And one senior NHS leader said that hospitals would grind to a halt as doctors and nurses from other departments are deployed to provide emergency cover in strike hit and A&E units. It would be interesting. It will be interesting to see if this happens. Between 30,000 and 40,000 nurses in England and Wales were already due to stage a fifth one-day stoppage of their campaign on February 6th. And then on Wednesday, the GMB, which I think is the ambulance union, announced that it would call 10,000 paramedics, call handlers, and other ambulance service staff out on the same date as one of four of its days of its own strike. So they're getting together. They're doing the thing. Good luck to them. I hope they see change because they get paid nothing, like absolutely nothing. I think, I don't even remember. We talked about the average salaries in that video. It was low, like 25,000, 30,000 as a nurse with like a cap of like 40. It was not in any way an ideal situation. Not at all. Not good at all. Let me see. But the system is terrible. Yeah, our system is terrible. Yeah, I 1,000% agree. But with all things, people who are trying to make money, right? It's a system that makes millions and billions of dollars. So they're going to try to implement that, right? And it sounds like in the UK, they've been trying to maybe think about doing like privatized healthcare for a long time, like we have. The people don't obviously want it, but if you keep pulling it apart, the evil alternative, which is what we have, probably looks like, well, at least it's something. I don't know. It's a mess, friends. It's an absolute mess. Grassroots says the NHS is falling apart. Healthcare pendulum is swung and the wrecking ball is swinging hard. It really is. People are really over it. Really, really, really over it. If you want to hear more about system, what is kind of going on like this from people who actually work in it, like the NHS, I have left in the description 2 TikTok accounts. One is Siobhan, and the other is another nurse who works in the system in Scotland. And it's interesting to follow from people, I think, who are like in it and doing the thing. And they're also on Twitter, but I am not a human of the Twitter. So I didn't leave those links. You can go find them though. They're linked on their handles for TikTok. And it's interesting. Grassroots says, I found the BBC reporting on this disgusting. If union busters were journalists, they're it. The reporting in the UK has been fascinating. Siobhan and I talked about this in that interview of the people as a whole really, really support nurses and paramedics and healthcare workers over in the UK, but you would not know it based on the media coverage. Like, I feel like she said that overwhelmingly the people support the nurses and all of them, but the media coverage is incredibly negative and like attacking them and being like, you're abandoning us. It's doing exactly what it does here, where the media coverage attacks nurses who try to strike. But here I feel like the general population, like half of them legitimately do hate nurses and think that, they should just work, we should work for free and be attacked and all of this stuff at work. There, it seems like people don't actually think that, but the media is presenting it that way, because I expected it to be like, oh, like here, where you're like fighting in the court of public opinion for people to think you're just trying to do the right thing. And she's like, oh no, everyone knows that this is like the right thing to do. It's just the media. So I thought that was like an interesting contrast that we had, right? That was going on here. I just thought that was interesting. Let me see. Justice. We are, as much as people in the US praise, we are actually, Justice, we're not going to talk about it tonight, but you and I have very different opinions of the assisted end of life type of stuff. I think, in my opinion, I think you're kind of twisting what it actually is saying. No one is forcing anything on people. And that way we're going to do a whole video on medical assistance in dying, which is something that Canada has come out with recently. I think it's going to be implemented here in the next couple of months. And we're going to talk about it a little on Friday, but not like dive into it. But I have a whole deep dive coming of how in Canada they've come out and they've changed a law surrounding like medical assistance in dying, if that's what you would choose to do if you meet certain requirements. And I think it's a much more humane way to treat people. So we'll talk about that then there. But yeah, I just saw your comment and we will be talking about that. So stay tuned if that's something you want to hear about. We've been doing like a bunch of research on it, and we kind of, I have big feelings about that because I've seen a lot of people suffer in their end of life. And clearly we've seen this kind of come to a head, which is what we'll talk about on Friday, where people feel the need to do absolutely wild things in order to feel like they can help their loved ones out of awful situations, into the form of doing really terrible things that they should not do. But, okay, time for another mouthwash. This one is just to rile some feathers. This is intermittent fasting. Okay. How do you feel about intermittent fasting? So there's a lot of research out on intermittent fasting, right? For most people who are doing intermittent fasting are trying to lose weight, right? And I've had many patients over the year that comes to me and they're like, what do you think about intermittent fasting? And I'm like, oh boy, to me, it sounds like hell because I require to eat every like hour and a half to 2 hours. Like I am a grazer. I wish I was like, I wish I could say like, I don't eat huge meals, but I like, I blame it on the fact that like I'm tall. I'm like 5'10", right? I'm like I require a lot of nutrition. I'm tall. It's fine. But I like to graze. If I don't graze throughout the day and have lots of snack, then I get cranky. There are people that swear up and down that like intermittent fasting is going to do all these different things. You're going to burn like other, it's going to like burn all this stuff. And there's been a lot of theories surrounding it. And patients would come to me. And my thing that I would tell them was it's not harmful. I don't think. I mean, it might be harmful if like your family member is like shoving food in your face and like eat. If you're all of a sudden your partner's like, I'm getting a divorce, like that might be harmful, right? Just evaluate where you're coming from. It might make you very angry and cranky, like I get hangry. Um, Evaluate that. But like on a whole, if you are otherwise like you don't have something that affects your metabolism, like diabetes, in general, I usually would tell people, I'm like, yeah, go for it, try it, see if it makes you rageful. And then if you're fine, then it's fine. And if not, then it's not for you and it's fine. But my theory in the back of my mind has always been that it's not, it doesn't do anything extra for you. If you're losing weight from intermittent fasting, it's because your eating window is so small. And if you aren't familiar with intermittent fasting, it's basically you only eat for like a 8 or a 6 hour chunk of time during a day, right? And then the rest of the day you only have, I don't know, like water or black coffee or something. And you to me that just sounds like I said like awful. But a lot of people in my opinion, I was like, well, you would lose weight, right? Because you're like busy in life, and so if you're eating for less hours, you're probably having less calories, like just by process of elimination here. I'm sure there's other science behind it. We're not going to dive like terribly deep into it. I did find an article though that agreed with me that was coming out this week, so I thought I would share it. I was going to link a article from now I forgot, Abby's Kitchen. She's a registered dietitian about this. She agrees with me too. So obviously that's the video I'll link, but I just thought it was fun because this gets people so riled up. So riled up. I have never seen statistical difference like any well documented anything that says like, oh, you burn whatever faster if you do intermittent fasting. I mostly honestly just put this in here though to rile people up. So I was right all along. Intermittent fasting may not be all that helpful for losing weight. Like anything above anything else, especially like long term, if you then go back to a normal thing. Yes, sounds kind of like a diet. Yes. And we know that most diets, right, aren't really doing anything in the long term. And here we are. That's where we are. A lot of people do, like Jazzy said, I had this talk with my pharmacist. Intermittent fasting has just happened naturally for me. I lost 6 pounds in starting new positions. Yeah, if you work like a lot of interesting shifts, you kind of like are forced into like intermittent fasting, depending on the unit that you work on. Right? They're like food. You can't eat that. What are you thinking, you silly goose? You don't have time to eat. Automatic intermittent fasting. But this one was basically just finding that our findings did not support the use of time restricted eating as a strategy for long term weight loss in a general medical population, which, I was like, I could have told you that. For as soon as as soon as my patients would go off of this, they would gain all the weight back. It wasn't usually sustainable long term. It was very effective while they were doing it, and then they regained it afterwards. So I was like, well, that just seems like you're torturing yourself and you're not getting any like long-term benefit over here. If you love intermittent fasting, you do you, friend. You do you. I hope you're not cranky. I hope you're not cranky. I hope you're okay. But yeah, I just thought that was interesting, and I threw this in here. We would throw it in there. That was a fun mouthwash. Let me know your feelings about intermittent fasting. I know sometimes I just poke the bear because I know people are going to have like big feelings and they're going to tell me all about them. And I'm like, thank you for the engagement. I appreciate it. I appreciate it. Natalie says the general medical population doesn't want to do lifestyle changes. So I think that is a bold statement that is slightly misleading, if we're being honest. I think most people do not have the bandwidth or the resources available to them to make lifestyle changes that would really make a huge impact, right? And like, do we really, at what cost, right? Because this is all also, we have to have like a cost benefit analysis. A lot of people don't have access to like sidewalks, right? They don't have anywhere to go. And if you're like, oh, just go on a walk, right? They don't have anywhere to go walk. They live on a main street. They don't have sidewalks on their street. They don't have a vehicle where they could go and drive somewhere. They can't afford a gym membership. A lot of people live in areas where for like food, they don't have a lot of like healthy food options, right? Or they don't have time because they are exhausted. I don't have energy to like cook healthy food because I'm working full time and I have two toddlers and I'm like, oh my gosh, like I am at my limit, right? So I just like to shy away from any kind of talk that says like, well, you just don't want this enough because it's like, my dude, oh, I would love to have like and I'm in a very privileged position of like, I have, all sorts of, conveniences and I can go walking. I can do all these different things. I could, uh, you know, get access to healthy food. I just think it's like very shaming when we say that to people as if like if you're not already at your wit's end, like and then kind of like adding this on top of it, shaming. So, if you want to lose weight and intermittent fasting gets you there, do it, my friend. Again, just be careful. If everyone is all of a sudden hating you, just introspection. But also, I'm very happy that I'm right. That this is not like the cure all to life, right? Not going to be that. And also, yes, Jazzy, I agree. Being hyper focused, especially on like what you eat, anything like that, that can be rough for a lot of people. And I have found a lot of people run into a lot of trouble with intermittent fasting, where they'll all of a sudden keep narrowing down their eating window and it just becomes a slippery slope. So if any way you struggle with like eating anything like that, then I think it's just something to approach with caution, my friends, right? Just approach with caution and be nice to yourself, right? Know that like we only have one, we only have one little skin suit. We should probably be like nice to it. So the one we got, just be gentle to it, a little less judgmental. This is also a pep talk to myself. I'm very judgmental of my skin suit. Okay. Very judgmental of it. But we should probably learn to love it a little bit more. Okay. Here's the argument, the article that annoyed me. Okay. Sometimes people post things and I'm just like, you are posting and I could punch you. Okay. And that was this article. And I found all of these. I was just like browsing the internet of like, what are the most popular like news stories that came up this week? And I saw a few people in my life like actually posting about like this crap. And I was like, oh my gosh, I just want to like, ugh, like why are we talking about this? So here was this article. Antidepressants can cause emotional blunting, a study shows. Widely used antidepressants cause emotional blunting, according to researchers that offer new insight into how drugs may work and use their possible side effects. Study found that healthy volunteers became less responsive. It goes through this whole thing of how they found that people might be more emotionally like blunted if you're taking like a SSRI or an SNRI. They first of all, totally botched the study because they did it at like, they'd only been taking the medicine for 21 days. We shouldn't even really look at any outcomes from SSRIs or SNRIs other than like, like side effect. We shouldn't even like look at those until you're like 6 weeks out, because 6 to 8 weeks is when those medicines start to actually work. But do they cause, this is a typical thing of where they're like, oh, well, it causes emotional blunting. And they're saying like it decreases some of your emotional, like you're not as sad, but you're also like not quite as happy. And they're framing it as if it's like this crazy unknown side effect in order to demonize a medicine. And my dudes, that is literally the point of a lot of like SSRIs and SNRIs, right? Is so that you take emotions that are like this and hopefully get them a little bit more like this. Now, I am not like all hail SSRIs and SNRIs. I think they can be very helpful in some people. I have taken Zoloft on and off. We've flirted with each other for a long time. We're currently broken up. I have taken them. I have seen them help in my life immensely. I have seen them help in my patient's life wildly, my friend's life wildly. Are they for everyone? No. Before you get prescribed them, should you have a very honest conversation about the side effects? Because there are side effects, my friends, and have a decision with your healthcare provider about like, oh, like this is, here are the pros and cons. here you are. Here's your information. Would you like to proceed? And some people are like, heck to the no. We have an option for you. That's our next article. And some people are like, yeah, that to me is worth it. And it can change based on where you are in life. Like some people take them forever and they're like, this works for me. I am down. Some people are like, I just needed this to kind of get through this experience. Right. And now I'm going to try back off of them and see if it's okay. Some people, we go back and forth. Um, but articles like this that say, like, you are emotionally blunted, that is in a way sort of the point, right, of the medicine. Like you don't want to be, I would tell my patients, like, if you are like not feeling any of the good, please, like, I want to, like, please let me know. These medicines do. They take you from super highs and super lows, right? Especially usually here, like super lows, and they kind of mellow things out a little bit, right? They are not perfect. Again, they are not perfect. There's all sorts of new research that's coming out that's saying, like, we don't even actually know maybe why these medicines work. And there's probably other interesting things that we should dive into and like look into more that might be more effective, but they are still overall effective for a lot of people. They help a lot of people, but demonizing them and saying that they're causing a bunch of emotional blunting, which is really just like kind of their point, right? Like they make it seem so bad when it's kind of like, well, like that's sort of the point. But also you should be educated that exactly emotional blunting is a little bit good if it keeps you from wanting to self-harm, right? Because that is never the goal. And I just hate how they demonize it. And I saw a lot of people reposting it and being like, see, these things are just like tranquilizers and blah, 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 blah. If you feel like that, like you're totally zonked, please talk to someone. They can probably adjust your dose, see if that's not a good fit for you. You can always, if you would like to explore other options. That's totally fine. But to label it like this is just disingenuous, disingenuous. Is that the word? And that's fine. There are definitely populations for which they do not work. I completely agree. I am not a like Zoloft for the entire world type of human. This is one of the resources that we have in our toolkit. I will explain it to you. If you would like to explore that option, wonderful. If you don't, you don't have to. Yeah, you're blunted, but you're alive. Sometimes that is very important. I have been at the point where I needed this for this exact reason. And I'm very grateful it exists because even if I couldn't feel like the super highs for a little while, we needed to not be where we were in terms of the low department. Okay. Got me back. We're fine. Very, very grateful for medicines like this that let me get through that and then get through COVID that were like, whoa, whoa, my dude. Whoa. And we see there are lots of other things, like I said, that we should explore, but these fear mongering articles just make me super duper mad. Jezzy's right. It's a tool. It's not for everyone, and that's okay. Yeah. You should have educated information about it. At least we stopped giving routine Haldol. There have been advances. There have. There's not. And there's a lot of other interesting good meds out there. They're just not covered by insurance, and you have to fail a lot of these other ones before you're allowed to try them. And even when you are, then they're super expensive. I'm hoping that kind of changes in the future. But there we are. So I have a whole video about the side effects of SSRIs and SNRIs because there are a lot. And I will leave it linked down in the description below, as well as some talking points you can bring up and just some things to consider if you're like someone who was considering ever taking medication for it. I have a couple videos about like my experience with Zoloft if you want to watch those. There are for some people it's helpful. For some people they'd rather go a different route, and that's totally fine. Don't ever let anyone force you into taking anything. Like if someone is like super hell-bent on like, well, here you go, you have to take this is the only solution, that person's probably scary and you should run away. But again, just one tool in the toolbox that you might be able to use. Here is another one that I saw that I thought was interesting. Mindfulness exercises can be as effective as anti-anxiety drugs, a study shows. Breathing and body exercises help to relieve anxiety as effectively as medication over an 8-week study of 208 people. And this is something that I've seen in a lot of people who have the ability to do this, right? And this is a huge caveat that I wanted to make here was, Adrian, we were talking about you earlier in our interview with Siobhan. Hello. doing things like this, uh, you know, having mindfulness practice, meditation, blah, blah, blah. This is something that can sometimes be like, yes, it's helpful, but it's just not something that like appeals to everyone, or some people just don't have time, or like they're not in a mental space to even get to this point, right? Which is why we have other options to help pull people out of sadness holes or pull people out of situations where they don't even feel like they can tackle this. But if you are a human who's like, I don't ever want to touch medicine for this, there are awesome things like this. And that is where alternative other things can come in. And I'm a huge fan of, just like I said, giving people all the options and seeing what resonates with them both. Personally, I could not even fathom doing something like meditation or mindfulness when I was in my pit of sadness, right? That was like, I was like, we couldn't do anything. We were not going to be meditating, right? Because the whole time we were, whatever I was meditating on was not something that I should have been meditating on. And we need to veer sharp left away from those thoughts. But for a lot of people, it can be very helpful. A recent study published in The Devil, JAMA Psychiatry, JAMA, showed that people who received 8 weeks of mindfulness based interventions experienced a decrease in anxiety that matched those who were prescribed escitalopram, which is Lexapro, a common anxiety medication. Under the brand name Lexapro. Thank you. A 7-point scale was used to assess anxiety among 208 participants. Representing going from like extreme anxiety to normal. By the end of the study, anxiety scores in both groups had declined an average of 3.09 in the people who were doing like mindfulness and all of that. Mindfulness practices are things like meditation, breathing exercises. They've been used for a long time to kind of like calm things down. And yeah, it basically goes on and talks about like different ways you can do that. Here's the thing though, in this study, like, and I'm all for it, right? I think if like other things that you can do that I've seen a lot of people have success with is like, my third eye is twitching. I am all for like doing whatever integrative therapy, like, sure, like let's let's do the meditation, let's do all the blah blah blah, whatever floats your boat that you have time for, as long as it supports you, I'm here for it. Things I'm not here for are when people are like, well, don't take medicine, just do this instead. Like, if you just exercised and ate really healthy and like did yoga and did some deep breathing, you wouldn't ever need medicine. Like, I hate that with a freaking passion, because that is not a privilege afforded to everyone. It's also you've probably never been very depressed. Because I can tell you that when you're real depressed, you're not doing any of those things. You're barely, if you're getting out of bed, it's a great day. A combo approach, exactly, Montana Gal, is great. And sometimes we have to get you to a place where you can do the combo approach and we can get there. And sometimes you just need this, and that's great. So I'm not pooping on this, but if you poop on my medicine that some people need, me included, I'll come get you. Also note that they attended 2.5-hour long classes with at-home exercises of 45 minutes and attended one-day mindfulness retreats 5 or 6 weeks into the course. Like, what? That's a lot. Who has access to that, right? Nobody. So there are still benefits, I think. A bunch of benefits for just like doing those things in general. I find like some like journaling or even just doing a relaxing activity. I think getting outside and like having some like sunshine on you does wonders. There's a lot of other ways to go about things. So this is a great demonstration that it doesn't have to be medicine. It can be both. You do you, whatever floats your boat. As long as you're not harming other people, you do you. I have a YouTube video down below that there's a person I follow on YouTube who I really like, who kind of goes into like psychology type stuff. She's a psychologist. And she talks about, I've watched some of her stuff when I was trying to, I like tried for a hot minute to get into like meditation and like mindfulness and like journaling. And it didn't go very well because I have ADHD and I sit there and I'm like, bing, 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 bing. And it makes me more anxious to sit there. Probably like means I should just, I don't know, try harder or do it. But then I was feeling bad about myself, which then made me depressed. So I stopped. I was like, I think this is this is going to be counterintuitive for me. Maybe we'll try some deep breathing or something like that. But I cannot sit here like this. This is not for me, which is also fine. But it helps a lot of people who are maybe just at baseline, a little bit more chill than I am. Adrian says calming the vagus nerve, i.e., the parasympathetic nervous systems, is a modulator of the brain and gut axis. Yes, there is a ton of research that shows, doing these types of things where you can big breaths. That's what you're kind of like trying to stimulate, is like to calm down that vagus nerve and be like, just shh, my darling, shh, it's okay. Take a deep breath and just like chill the F out for a second here. Okay. Very helpful. Giving your body healthy foods, all of that stuff, like to help with like your gut, all of that stuff is absolutely wonderful, right? And is going to help just make you feel like better all over. All very, very good things. Mr. Midwife says mental illness, including depression, is like your brain catching a cold or a flu. Oh, that's a very nice way to put it. I really like that. You can't just get over it. Sometimes you need medication to help. Oh, I like that. You should like do this for a living or something, Chad. You should. Headcamp says, when we can't get the motivation to get out of bed, the bills are due and the house is beyond a wreck, and you've neglected a relationship, deep breathing might not be the end all be all. Exactly. Neither is yoga. There we are. Music therapy, that would be a good option for ADHD. Humming, chanting, and singing may be better. Probably should have something like that. All I can say is menopause will just bust through it all. It came in like a wrecking ball. Mel said, I just logged in, but we have to do a mandatory stress study assignment as part of one of my clinical classes. It's really badly done and is only adding stress. That stinks. And I am sorry. I am very, very sorry. Yikers. But anyway, yeah. So there's some options, right? We're not going to bash medicine like that first article did and be like, oh, look, the effect that we kind of want to happen is happening, but we're calling it a side effect. And I was like, no, dude, we want that. We want that, my friend. That's kind of the whole point. But again, if there's too much of it, hop back. And if you are into this type of thing, like do it. Like really, I think it can be very, very helpful doing some kind of like mindfulness meditation practice. You can do it at nighttime to like right before you go to sleep. I always fall asleep when I do that. But I get the little point on my like Peloton tracker. It's like, oh, you meditated. I'm like, I was sleeping. But thank you. I'm very glad I'm keeping my streak going. Something like that can be very, very helpful. And now science backs us up. Yay, science. Hooray. But you might not have 2.5 hours. It's like a really long time. And then I also have issues with like articles when they say things like that. And they're like, oh, this is just as effective in clinical studies. I'm like, yeah, but like one of those things takes like, a lot less time than 2.5 hours. 2.5 hours. That's like a lot. I can't do that. No, thank you. Nurse Adrian says, also for ADHD, I highly suggest Kundalini or Tibetan yoga because they involve more movement. Oh, but what if I'm lazy? I'll have to look into it. I don't know anything about that. Yes. Oh, and therapy too. Yeah, therapy. Really, I think the best of all of this, the thing that I've seen the most success with, and the research says is the most success, is if you're doing like combinations of different things, right? If you're doing like like moving your body every day, trying to feed it nice foods, doing a little bit of like meditation or something, and then go into therapy or like sprinkling in some store-bought serotonin and doing some therapy, a combination approach, always the best. But again, can be difficult if you're in a pit of sadness. If you are looking for a therapist, Psychology Today is a website, and it can kind of help you pare down and narrow one. I've been on there a lot lately. They're like nobody in my area that does therapy that's covered by my insurance. I'm finding no one takes insurance. I am allowed 10 whole visits with we bought like my husband finally has like, he's not a contractor at his job. He was hired as an employee of the company, and they have okay-ish, very expensive insurance, but like okay-ish, better than we've always had like I'm going to pay you all my money and it's still going to be $8,000 before you give me absolutely anything. And now we pay all of the money and we only have to pay $2,000 before they give us anything. And we get to go to therapy for 10 times in a year for free, which I was very excited about until I realized that no one in my area except for one person takes my insurance, and it's not going to work out because we just don't align in any way. It wouldn't be a very good fit. I'm like, the things I want to talk to you about are like the things that like trouble me, or the things that like you really love. So like, we probably shouldn't do this. So yeah. So Psychology Today can be great if you have people in your area that take your insurance. It gives you a ton though who don't, even if they don't take insurance, you can narrow down and be like, hey, I'm struggling with I don't know, PTSD symptoms of this, or I need like a marriage and family, like a therapist to work on my relationship, whatever you need. You can type all that in. You prefer to see this provider. You want to see someone who is LGBTQ, affirm it, like who's like, not going to shame you for that and be fine with it. You can type in all of those things, right? And it's very helpful. You just kind of can be, screwed if you actually want to use your insurance. And they're all like, no, except for this one person who's kind of problematic. And you're like, I'm not going to go talk to you. My brain would melt. No, thank you. All right. Are we ready for the good news of the week? We kind of had good news to start. We're bookending. We're improving here. We're getting very positive. We had good news to start with that I still managed to twinge with kind of a little bit of rage. But now we're ending with dun, dun, dun. COVID, flu, and RSV are declining in hospitals as the tripledemic fades. I kind of hate the word tripledemic, but it's fine. But this is excellent, right? Especially if you work in hospitals. Really, if you're in any way in the healthcare system, you're going to stop seeing, like, there's just going to be less inundated of all of this. Cold and flu season is normally life-sucking, right? I used to dread it with every bone in my being, both inpatient as a nurse and then outpatient, because inpatient, you were gowning up to high heaven for every single room because everyone was covered in snot and boogers. And it was just gross. And outpatient, I was so tired of telling people you don't need an antibiotic for your cold that I like was just gonna go punch a wall. I'm in charge of my emotions. Everything's fine. But cold and flu and RSV, like this season especially, was brutal, right? I think the most recent ones have just been absolutely brutal. Because we had the trio going on here and it is getting better, right? We've seen hospitals that have just been absolutely swamped for the last few months. And yeah, Adrian's not ready. I feel so afraid to be optimistic about the tripledemic. It seems too early to tell. I'm leaning into it. It seems very optimistic, but I'm like, let's go. Hospitals have just been overwhelmed, obviously just crazy with this kind of stuff. And it seems like it might be slowly starting to get a little bit better. So we're just going to accept this as fact. Washington Post, sure. You are where all of my hope lies now. I don't know if that's good or bad. I don't know anything about the Washington Post. Grassroots has yet to see it subsiding. I'm hopeful. I hope it starts happening, right? I hope we start to kind of like get over this hump and then it just gets a little bit better. I hope. You get a little red, a little yellow dress than you do. But yeah, Montana Gal, I would hate it too if people sneezed directly into my face. Yeah, that was always a lovely feature of cold and flu season, was people sneezing directly into your face. That was how one of the things that sent me into I don't know if I can do this anymore, was all the people that coughed with COVID in my face after lying and saying they didn't have a cough. And then they would come back into my office and like, I was wearing a mask, right? Because, obviously we all were, but then they would just come in like back and like spray everywhere. And they're like, oh, I think I have COVID. I'm like, you just told my receptionist you didn't think you did. And then you told the MA you didn't think you did. And now you're here coughing all over my office, getting my other patients sick. And then terrible things happen. Anyway, this was supposed to be good news. Sorry, Liz, we need a new good news. That was it. Our only other mouthwash that we had for today was scrubs, and then we all realized we were all very sad, because black scrubs were the worst. So, everything I tried to make good today, I made bad. So, story of my life. Story of my life. And it's not gone. Jazzy said I'm still getting a lot of referrals for COVID. Um, a lot of inmates have COVID right now. I don't think it's going away. I don't think it's like going anywhere. This one random website told me that it might be getting better. A few other ones agreed with it too. I don't know where they got their data from, but it seems like maybe we might be getting over the hump. Let me know if you're watching this, well, now or on the replay. Are you seeing any decrease? Are we seeing any projections of this getting any bit better? More mouthwash needed. I'm sorry. I'm sorry. We tried to have good mouthwash for this episode, but it's not working. Let's all go cry into our black scrubs when this is over. Exactly. Exactly. But at least it's dark so that it will hide our tears, right? If you're wearing light blue scrubs, like light blue scrubs or green scrubs, you're going to see the tears all over the scrubs. That's gross. That's gross. We don't want this. Um, after watching Hogue so long, I don't trust any articles. Oh, also a good point. Um, if you guys, I've talked about him before on this channel. If you guys are interested in like anything related to like current events, he kind of does like this type of thing, but like picks one article because he doesn't have ADHD and he's able to focus. He's a lawyer and he goes over like current events, but also like that are in the news. Really breaks down articles, teaches you like he points out, like Jazzy said, like a lot of interesting things where you're like, oh, like everything is a lie. Everything I'm being fed is a lie. Breaks the arguments down from like a lawyer's perspective, is very level headed. He is the opposite of me in every way. Lawyer things, uh, obviously not healthcare related, but he is a phenomenal creator on YouTube. I'll go and find a link to his channel. He does like these things every weekday morning. Usually, he had a stroke in the I think at the end of December and is now in rehab. But if you're looking for like a YouTube channel to support and go and just watch, obviously he's not making YouTube videos right now because he had a stroke and he is currently in rehab. But if you are just interested, he has a lot of very cool, like fascinating breakdowns of stuff. That's worth watching. So if you're looking for like just a chatty kind of like daily show where you're like, I want to be cynical and I want to break down news and I never want to trust anything ever again, go over there. They're really interesting. Usually I'm over there like watching kind of in the morning, and supporting his YouTube channel right now is really important because he's not on it. Obviously he had a stroke. And so watching like like watching other videos just keeps you up in the algorithm. And is very helpful so your channel doesn't die. Because if you disappear from YouTube, the YouTube gods hate you and they will go and try to, they don't recommend you to anyone anymore. So by helping keep someone's channel alive while they are recovering from a freaking stroke is huge. He is one of my favorite people on the YouTubes. Seriously, even if you think like, I don't want to watch like a lawyer, blah, blah, blah. He is fascinating. And a general overall, just a very lovely human. And he's from Michigan. And I loved living in Michigan. We lived very close to each other. Let me find his YouTube channel and I'll put it in the chat. He also does like he did like a Dungeons and Dragons thing, which if you like that, I didn't know. I've never seen anything like Dungeons and Dragons. That's not ever been my scene. It was the funniest thing that I've ever seen. It was called Lawyers and Dragons, and they brought someone in to like do it, and it's like storytelling. Basically, they made up this adventure with a whole bunch of lawyers who were on like LawTube, which is why I'm trying to make NurseTube a thing. Because I was like, this is amazing, and you're all like internet friends, and we're gonna do this. So that's why we have Fridays, is I'm trying to drag everyone in with me to make like a nursing community on the YouTube. Anyway, that was a lot of information to say. Go check out this channel. Highly recommend. Let me find I'll just link the most recent one. What was this? Where's a good one? Mickey Mouse. We'll do a Disneyland one. Find one that wasn't like too too heavy in the lore of other things that are like going on with his channel. But definitely go and watch. Yeah, long live the fanny pack. Yes, we have our fanny pack. Grassroots said, I'm so sad now. I haven't seen his stuff in a while, and he's amazing. Yeah, he is doing, it sounds like better. His wife updates. It was just rough. He was in the ICU for a long time. He had a rough go of it, but I think he, the last time I saw was like hoping to get back to YouTube in a couple of months. So there we go. That is in a weird way, good news. Yeah, his wife said he's doing pretty good. He is. So that's good. Yay. Hooray. She updates a lot on Twitter. And that was literally the reason I got a Twitter was this happening. Cause I was like, I need updates. Like it's weird when like someone who you follow on social media, right? It's those like parasocial relationship things where I was worried, right? I was like, oh, like I am genuinely like worried, about the situation. And here we are, but he's doing better. All is well. This is Emily D. Baker's Kersey jar. Yeah. This would be the Emily D. Baker side of Nurse Tube. My sister texted me. She's like, I wondered why you joined the cesspool of Twitter. Yes. Yes. Yeah. And if you comment on videos, interact with them, like, even if you just like them or leave a comment, just literally, I don't know, tell him, I don't know, where you live. Tell him Michigan is great, or make a snarky comment about like how much you hate Michigan football because he's obsessed with Michigan football. Probably respond to you. Actually, don't do that. You might have another stroke. We don't want that. The jail nurse email me here and we can discuss. We have a few things coming up that talking to someone who works in a jail, which I'm assuming you might, based on your username, would be lovely and helpful. So just email me. There we go. Yeah, I know. I don't either usually buy into like the parasocial relationships, but I was sad. I think because I watch his stuff every morning. Like once I have work, I have meetings in the morning super early because a lot of people I work with in Germany. Oh, sorry, I just bumped you. And then I would watch that stuff while I was like, making breakfast and getting the girls off to preschool. It was just like, it was weird. I was like, oh, this is sad, but he's doing better. So that is wonderful. There is our good news, is that Hogue is getting better, and yay. There we go. Okay, friends, that's what we've got for this week. Let me know if you liked all the random news stories. I'll pretend to take your input. Just kidding. I really will. I need you all to also want to be here with me. I like seeing what happens in the world each week. That's why I kind of thought of doing this. It was also inspired kind of by like a lot of people on like LawTube, which I enjoy watching because in my spare time, I like to pretend I'm a lawyer. I'm not, but I'm like, do I want to go to law school? No. Maybe I can absorb it all through LawTube. And they kind of do these like weekly recaps. And I was like, I love it. I'm going to do it for healthcare. And then I picked 8 million topics. So let me know if you liked it. And we will see where we go going forward. I'm kind of having a channel life crisis where I'm like, I don't know what I want to do here. What are we doing? There we are. If you have any topics, so we're just going to get through it. If you have topics you wanted to ever discussed on the channel, do email them to me here. Right here. I will find them. I will be like, yes, thank you. I appreciate it. That's an excellent way to know what people actually want to hear about in life. And yes, I'll see you on Friday when we're going to discuss with the group at 3 p.m. Eastern time, the whole hostage situation, end of life type of stuff. And yeah. All right, friends. Do all the YouTubey things. Give the YouTube gods their toll. Like the video, whatever, leave a comment, do all the things. If you want to, you don't have to. I will see you on Friday. I hope you know that you, my friends, you're not alone. You're more than enough, and you can do all the hard things. Until next time, bye-bye.